So today on my Instagram Live, I'm going to talk about testosterone. I know I've spoken about it before, and I'm sure this won't be the last time I'll talk about it. But it's just one of these forgotten hormones, and I'm really not sure why. I'm very embarrassed to tell you, and I'm quite happy to admit, that when I qualified as a doctor in 1994, many years ago now, I had no idea that women produce testosterone. I knew about men and testosterone because it's always mentioned, isn't it? Men with their aggression, with their testosterone, with being more macho, having more muscles. It's all about testosterone. But I didn't really understand how testosterone worked in our bodies. When the NICE menopause guidance first came out in the UK in 2015, they mentioned testosterone could be considered to improve libido in women taking HRT. I'd gone to a few lectures before this time, started to develop my interest in menopause, and I'd heard the word testosterone in women in the same sentence. And I've got quite an inquisitive mind. So once I heard testosterone and menopause in the same sentence, I thought I need to know more about it. What is going on? I didn't even know women produce testosterone. Where is it produced? What does it, how does it, what effects does it have in the body? Is it a good thing we produce testosterone? And how do testosterone levels decline as we get older? Is it related to menopause? Is it age? What determines our testosterone levels and so forth? So I've got a huge number of questions in my head, and the more I learn about testosterone in women, the more I've got more questions and want to develop a better understanding. But also, the more I realise that the more I speak about testosterone, the more confusion there is out there and the misinterpretation of things as well. So I know I've spoken about testosterone before, and I've done some great podcasts about it. I've also got YouTubes as well about testosterone. But I thought I'd just give you a bit more of a scientific overview, if you like. I've had a huge number of questions, so thank you so much for all your questions. And what is shining through from your questions is how hard it is for women to access testosterone. Now, testosterone was discovered many years ago in the 1930s at a similar time that estrogen, the active form of estrogen, estradiol, progesterone, were discovered as well. And once people discovered these hormones, there was a great race actually to make them chemically. So this meant they had to be synthetically altered so that they could go to market. Because people wanted to make money, they always want to make money out of medication. And they knew that if they were the natural hormones, they were initially people could buy them over the counter, but they wanted them to be controlled so that people had to have them prescribed. They had to see doctors, usually gynecologists, and a lot of money has been made traditionally from hormones, but the synthetic hormones. I've spoken before at length about body identical hormones and how the synthetic estrogen and progesterone are actually now made in contraception and older types of HRT. And this is really important when we're thinking about testosterone, because actually when we prescribe testosterone, there's a warning with it. People call it like it's a controlled drug, so it's got more sort of regulations around prescribing it. People refer to it as an anabolic steroid. It's abused in various groups, but this is where people are not understanding the difference between natural testosterone and synthetic testosterone. So the anabolic steroids, the abuse of drugs that are called testosterone in certain groups, are actually synthetic testosterones. They've been chemically altered. So they have very different metabolic, biological effects in the body, and they have different side effects and risks. So it's like comparing a natural progesterone with a synthetic progesterone. I've said many times before, the synthetic progestrogens have a small risk of clot. They have a small risk of heart disease. They might have a small risk of cancer associated with them too. It's the same when we look at testosterones. We have to be very careful and specific what we're talking about. Are we talking about natural testosterone that we produce, women and men in their bodies, and we can get the natural, biologically active, biochemically exactly the same looking testosterone to prescribe? Or are we talking about synthetic testosterones that are often injectable? There are some tablets, and they have been chemically altered, so they are not the same metabolically and biologically in the body, and they're associated with risks. So the more we talk about that and understand it, that is really important. So when we talk about any risks of testosterone, any metabolic risks, any cardiovascular risks, it's because people have got the natural and synthetic hormones confused. Of course, our body is designed to have hormones. Hormones are just chemical messengers. They work all around the body. So testosterone is no different. It's such a shame it was labelled as testosterone because it was then thought it's only produced by the male testes. And of course it isn't. It is produced by the testes, but it's produced from other places as well. So for women, for example, we produce about half of our testosterone from our ovaries. We also make it in our adrenal glands. We can also make it in our muscles and our bones, but also we can make it in our brain as well. And that's really, really important to know that. We know that levels of testosterone are greater than levels of other hormones, including estrogen, when we're younger. And it's a bit mind-blowing, isn't it, to think we have more testosterone than estrogen in our bodies when we're younger. And often what happens, levels of testosterone decline with age. So it's not a menopause-related decline, it's often an age-related decline. And this decline can sometimes start in the late 20s, early 30s. Some women it might be even younger. And some women, of course, it will be older. Some people talk about testosterone levels reducing and then increasing a little bit as we age. The truth is we don't really know, because who measures their testosterone levels? How do we know? So the sample sizes of people have been quite small, so we don't really know exactly. And us as individuals, before I started taking testosterone, I had no idea what my testosterone level was in my 20s, 30s and 40s. And testosterone levels will change throughout the day. They'll change depending on whether we exercise, what else is going on with other hormones in our bodies as well. And actually testosterone levels change throughout the menstrual cycle. Testosterone can help with ovulation. So there's a little surge of testosterone when we produce an egg, when we ovulate mid-cycle, and then testosterone levels can decline a bit before our periods. So if we had our testosterone levels done at every single day when we're having our periods, levels are going to change. So levels are only a guide anyway, as I'm sure you realise. But if someone has their ovaries removed, for example, if they have endometriosis or cysts on their ovaries, then obviously their testosterone level is going to decline very quickly because of this surgical menopause, which I've spoken about before. And in that case, low testosterone can be associated with menopause. So when we talk about menopause, as you know, we usually talk about low estrogen, low progesterone, and then we talk about testosterone as well because it's an important hormone, but it's not really in context of menopause. It's usually related to age, unless someone has their ovaries removed or they're damaged, for example, by radiotherapy or certain medication, for example. So just to sort of reduce that confusion. Now, testosterone works in many, many ways throughout the body. There are cells that respond to testosterone all around our body. Every single cell actually has a testosterone receptor in it. So it's not just certain areas of our brain, it's not just certain areas of our body. Testosterone works everywhere and it's metabolically very active. When you look at how testosterone is formed, it's actually made from progesterone. Before progesterone is cholesterol, and we have various enzymes that break down these substances to form the hormones that we need. So progesterone gets converted to testosterone. Testosterone gets converted to estradiol. It gets aromatase to estradiol. And so there is this sort of flow really. And you might have listened to my podcast, and I really recommend you do, with Professor Mo Curett, talking about this triangle of hormones. And he mentioned it actually in Steve Bartlett's great podcast that's just been launched recently, and talks about the triangle of hormones: estradiol, progesterone, testosterone. Now, for far too long, we've only talked about estradiol, or estrogen, and progesterone. And some women have only talked about one hormone if they've had a hysterectomy. But actually, they're three hormones. And we've got lots of other hormones as well. So I'm not quite sure why we're just ignoring one or two hormones to the detriment of women. So when we look at about how it works in the body, it works in a myriad of ways. It can help our cells to work better. It can help our mitochondria, the powerhouse of our cells, to improve their function. It can actually have genetic changes as well. But in the brain, it helps with the connections. We've got lots of neural connections, this whole network of nerves around our brain that actually then come down out of our brain through our peripheral nervous system, so affect the way our muscles and joints work, the way our skin sensation is, for example, as well. And testosterone has an effect on how it works. It's very anti-inflammatory. Testosterone reduces inflammation as well, and often actually more than estradiol can reduce inflammation. It can affect the way our inflammatory cells, our cells that fight infection as well as inflammation, work. They are more efficient in the presence of testosterone. So when we know how it works throughout our body, it's then easier to work out what happens when we don't have it. And like I say, our levels decline at different rates. So some people will not miss testosterone at all, and others will. Some will have more symptoms of testosterone deficiency, and some people will have very few symptoms of testosterone deficiency. Symptoms of testosterone deficiency can really vary between women. And for a very long time, in women, the only studies really have been done looking at libido, because many years ago in the 1930s, they documented that libido can improve if women take testosterone. Women who have low testosterone with reduced libido, giving testosterone back increases libido. And libido actually means sexual, pleasure of sex, but it can be pleasure of life as well. But for many academic studies, it's been misinterpreted or interpreted, depending on how you view the meaning of libido, as reduced sexual desire. And this has then, I think, denigrated women into being sexual objects. And of course, as a doctor, I'm very open talking about sex. Sex is very important, but it's not what defines us as a women. There are lots of women out there who aren't in sexual relationships or don't want to be in sexual relationships, or sexual desire is not a big thing for them anymore. So they shouldn't be judged in that way, and they shouldn't be denied testosterone because sex isn't on the agenda for them. No one as a doctor should be judging other people anyway, and I also think to assess sexual desire is very subjective. So to give us people questionnaires, make it very clinical, when it's something that is multifactorial. Sexual desire is not about a hormone. It's a multitude of factors that also with a hormone can improve or worsen if you don't have that hormone. But actually there is lots of reasons why sexual desire can change. And to make it very clinical to say that women have to fulfill a certain criteria to show how distressed they are with their reduced sexual desire before a doctor even thinking about testosterone, I think actually is going back in time. It's very barbaric, it's very judgmental. It's something that I feel personally as a doctor very uncomfortable grilling patients about how bad their sexual desire is before they can be considered with testosterone. And the more some people debate about testosterone, the more some clinicians are really digging their heels in. And I've read some terrible letters actually from other doctors refusing women testosterone because their sexual libido or their desire for sex isn't affecting them bad enough, which, this is a whole other conversation, but I don't feel as doctors we should be the ones judging a patient's libido. If they have any issues with libido and reduced testosterone is contributing to that, then it doesn't feel right that we are not allowing women to have their natural hormone back. But we've known since the 1930s, 40s, when people did studies about testosterone and libido, that it wasn't just libido that was improving, well-being was improving. Now, well-being is quite hard to measure. It affects us in different ways. So a lot of people say to me, do you know what, Dr. Newson, since I've been taking testosterone, I've been singing in the shower. One lady told me recently that her children commented that they've seen her teeth because she's been smiling more. That sparkle in her eyes, that joie de vivre, the opening of the blinds in the morning and smiling because the sun's there. Looking at the minute in the UK, we've got quite a lot of ice and snow. And actually I'm looking at it thinking how beautiful it looks. Before testosterone, I would have told you what a nightmare because the roads are icy, takes longer to drive, there's some fog, and I would have just thought about the negative aspects. And so these things are very hard to measure in studies, and that's why people have resorted to thinking about sexual desire, giving people a questionnaire, having this new definition called hypoactive sexual desire disorder, HSDD, to try and put people into a category. But what I've spent some time doing today is printing off some articles, and I'm going to write a review about testosterone, about how it works biologically in the body, with two wonderful American doctors who are great colleagues and friends. So I'm sure you'll know Kelly Casperson and Mo Kira. And I've been pestering them today to say, can we write a review paper about the biological effects of testosterone in the body? So watch this space, we're going to get cracking. So, but just to talk through some of these papers, I think it's really interesting to share with you. And one of the problems I think over the last decade, or maybe century actually, is that women have been treated quite as if they're quite stupid, especially people who aren't medical. Now, I know that I share a lot of information with lots of people all the time, and it's a real privilege to be doing this. But the more I can share academic papers with you, the more you can read and decide for yourselves. You know, this is a choice. One lady, one of her questions said, "Why are you pushing testosterone?" I'm not pushing testosterone, I'm just allowing people to have information. And also, just to let you know, I do no paid work with any pharmaceutical companies, including those who make testosterone. So just to be really clear, I don't have another agenda. So this is one paper showing the effects of androgens, so testosterone, combined with HRT on quality of life in postmenopausal women with sexual dysfunction. So it shows that sexual function can improve, but also quality of life. We cannot underestimate quality of life in us as women. And if taking testosterone improves quality of life by even a small amount, we shouldn't be denying it if that's what people want. Now, a lot of people talk about giving testosterone when women have had HRT for a length of time. And that's partly, when I've quizzed people at conferences, it's partly because they actually want to be sure that a woman is proper estrogenized so that she doesn't have any vaginal dryness or soreness when her libido comes back and her sexual desire improves. Now, I think that, again, isn't right, because we're all different, and many of us aren't taking it just for reduced sexual desire, because we know it has other benefits, including improving well-being. So there isn't really a sort of biological or science or evidence-based reason that we have to have HRT on board first. It's just traditionally that's what people done, because I think they're trying to reduce the number of people that take testosterone. We see some women in the clinic who have very regular periods. They're obviously still producing estrogen and progesterone, but they have symptoms of testosterone deficiency. They have reduced sexual desire, reduced libido, they have low mood, reduced motivation, poor memory, muscle and joint pains, headaches, poor sleep. These are all symptoms that could be testosterone deficiency. Of course, they could be symptoms of other things as well, and we often do screening blood tests, ask all sorts of other questions to ascertain whether it could be related to low testosterone or not. And if testosterone is low, and we think it could be, or some of their symptoms could be related to low testosterone, we give a therapeutic trial. So we try testosterone, assess levels and see if people improve, which is not an unreasonable thing to do, but increasingly I'm seeing more women who have low testosterone, and their estrogen and progesterone actually are not very low. And so we sometimes try testosterone with the HRT rather than waiting for the HRT to see the effects that has and then add in testosterone. Everyone's different, and seeing a specialist who really understands the role of hormones is really important. In my Newson Health clinic, I employ 70 clinicians, and we all have a lot of experience, clinical experience, in prescribing testosterone in the right way to the right person with the right dose as well, in a way that patients understand, but they are in charge of their consultation. So this is a paper that I'm really proud of. It's called The Effect of Transdermal Testosterone Therapy on Mood and Cognitive Symptoms in Peri- and Postmenopausal Women, a pilot study. Now, this is a paper that my research team have produced. So my clinic funds a small research team who are absolutely phenomenal. We've got really good data analysts and really good medical writers as well. So it's a real honour actually to be able to show you this peer-reviewed paper in a journal showing that actually obviously sexual desire improves when transdermal, so through the skin, testosterone is given to women on HRT. But more importantly, symptoms of low mood improve, symptoms of memory improve on women taking testosterone. And when we know about how testosterone works in the brain, it's actually no surprise, but we see it all the time. We've seen thousands of women over the years using testosterone and telling us, and we can see on their questionnaires, that their mood improves. They have less anxiety, they think clearer, they remember things better, they're sleeping better, their motivation is better, their reduced self-esteem, low self-worth has improved. A lot of women I see who've come from psychiatric units have been under psychiatrists, having quite heavy duty drugs such as antipsychotics, lithium, even ketamine infusions, actually find that their mental health has improved the most when testosterone is added, more than any other medication. It's all very subjective, so it's about finding the right person at the right time to give the right hormone or the right medication to. We can give testosterone with other medication because it's just a natural hormone. So when people are on psychiatric medication, we can add in testosterone, usually very safely, to their medication and monitor the clinical response. We work very closely with psychiatrists, and often with time, as people improve, they can gradually reduce their medication. But we do that with careful monitoring, of course, as well. But this study just shows and highlights that in a clinical setting, we notice this improvement. Now, some people will say, well, you have to have a randomised controlled study, otherwise it's not worth looking at. But actually, you can't always do randomised controlled studies. For example, this is quite an extreme case, but just to highlight to you, if you were testing a new parachute, you wouldn't do a randomised controlled placebo study. You wouldn't get somebody to wear something that looked like a parachute on their back and get them to jump out of an aeroplane. And actually to get results can take a long, long time, and then you're potentially denying people an evidence-based treatment. If I was, well, I've been on testosterone for about 8 years, but if I was offered to be entered into a randomised controlled study where I would have a 50% chance of placebo or testosterone when I was experiencing symptoms 8 years ago, actually I would be very reserved in entering a study if I knew that I could get testosterone elsewhere, because without testosterone, I actually can't work as a doctor. I can't concentrate, I can't think, I can't remember things, I can't sleep. It has a really awful effect on me if I don't have testosterone. And I know that because the way testosterone has improved me without changing anything else. So it's, again, we need more studies, and there are big studies being undertaken, but the results are going to take many years for these studies to come out. In the meantime, we use our clinical experience and knowledge and observational studies like this one to help formulate our sort of decision making in clinic. So thinking about the effects on the brain, so our brain has got all these nerves, like I say, in it, and our nerves are fire the messages fire from the brain to various areas of the brain and the body to let it know what to do. And it's a bit like a sort of an electricity going down a nerve, and we want the nerves to work really quickly. So for example, if I'm putting my hand on a hot kettle, I want my brain to tell me very quickly that's hot so I can move my hand, and I want my brain to tell my hand to move. So lots of things happen in literally microseconds, and we need that. Now, there's something called the myelin sheath, which actually builds the nerves and helps this conduction go very, very fast. And myelin sheath can get thinner and not as effective as we age. But guess what? Testosterone helps build this myelin sheath. We know people with multiple sclerosis, for example, it's often the myelin that's damaged. And some of this might, we don't know because the studies haven't been done really, be associated with low testosterone. And maybe that's the reason why multiple sclerosis is more common in women than men. And this is a great paper about testosterone and myelin, how the myelin can be regenerated in the central nervous system and the peripheral nervous system by testosterone. So really interesting when we think, and that does make so much more sense. A lot of people find that they have pins and needles that improve when they have testosterone. They might have tinnitus as well, the ringing in their ears, which again can improve with testosterone. Their mental clarity can come back. The brain fog improves. These connections just like open up and a lot faster in the brain because of the presence of testosterone having this really important effect on our central nervous system. And thinking again about memory, about learning, about recall. This is just a pilot study, but it does show that testosterone can improve both verbal learning, and memory in menopausal women. Again, just highlighting that it's sort of common sense really. If you know how testosterone works in the brain, then it's not surprising that memory will improve. And a lot of people come to our clinic worried that they've got dementia because they've got this word finding inability. They know what they want to say, but they can't quite say it. They can't remember people's names. They can't remember passwords. They can't remember things that are very obvious. I know when I started to develop symptoms, I couldn't remember drug doses. I couldn't even remember some drug names. And I was really questioning my ability to be able to function and work as a doctor until I had testosterone and I could almost feel my brain coming back into gear. So this is an interesting study. Then thinking also not just about nerves, but about pain as well. Now we have pain receptors in various areas of our brain, and our pain receptors can be modulated by our hormones. Now estradiol can modulate our pain receptors. As you know, before our periods when levels of estradiol and progesterone drop, people often develop a different experience with pain. They feel pain more severely, and it's often even with the same stimulus, their sensation, their ability to respond to pain changes when hormone levels are low. But also with the absence or presence of testosterone as well. And we know, and I've spoken about it before, fibromyalgia is far more common in women than men. And we know that a lot of women with fibromyalgia are perimenopausal or menopausal. Many of them will have low testosterone that will be not recognised. And this is actually looking at the pharmacokinetics, so the way that a drug works. And they were looking at testosterone gel in people with fibromyalgia and assessing their clinical response. And this showed that people with symptoms of fibromyalgia improve when they're given testosterone. And that's what we see so often in the clinic. And in fact, now in my clinical practice, I wouldn't diagnose fibromyalgia until someone had their all three hormones, especially testosterone, rebalanced. And then thinking about inflammation in the muscles and joints as well. Kelly Casperson actually shared me this great paper, thanks Kelly, showing the correlation between low testosterone levels and the risk of osteoarthritis, wear and tear arthritis. And this was looking at 5 years of data and showing that people who had low testosterone levels were more likely to have osteoarthritis. No surprise, because all three hormones actually, estradiol, progesterone, testosterone, are very anti-inflammatory in our joints as well. Really important, isn't it, when we're thinking about disease prevention? All of us want to reduce our risk of diseases. We want to do a lot of exercise, we want to eat anti-inflammatory diets, but we can't keep neglecting hormones which reduce inflammation in our body and our joints. Then this is a great paper. It's a review of the benefits and risks of testosterone replacement therapy. Quite a few people have been asking about risks. A lot of doctors are scared about potential risks. But actually all we're doing when we give testosterone is replacing what's missing in the body. We're not going supraphysiologically. We're not doing any gender reassignment work. All we're doing is just giving back a low level. So we're replacing the bit that's missing. So we give very low doses, we monitor levels, we check for side effects. The commonest side effect is hair growth, where we rub it, the cream or the gel on the leg, and it can be really vary. Sometimes, I know myself, I've used the cream for many years, but sometimes I look down and there's a lot of hair on my leg. Other times I'll have months and months without that, and I've not changed the dose at all. It's just the way our body responds, I guess. But systemic hair growth is very, very uncommon. Certainly we don't see people with beards, we don't see people with a lot of facial hair. If people do have facial hair, obviously we check levels to make sure they're not too high a level, and it might be those people who have had facial hair before. Voice changes. I've seen a couple of patients with voice changes. One was an opera singer, and so it was really affecting her work, so she reduced her testosterone, but then her symptoms came back, so she's actually just changing her voice with her voice coach, because the benefits of testosterone for her outweigh any risk with her voice. But it's very unusual. Most people don't have voice changes. Other skin changes, it can actually be beneficial to the skin. And some people talk about enlargement of the clitoris. Often people find during perimenopause and menopause the clitoris actually shrinks, so it can grow back. But I don't see people with big dangling clitoris between their legs when they have testosterone. So the benefits really do outweigh, and this paper's great for that. I've already mentioned before about mitochondrial function. So mitochondria, the powerhouse of our cells, and I've said before, estradiol and progesterone have a very beneficial effect on mitochondria, but actually testosterone does here, and this paper talks about how testosterone protects mitochondrial function. And it also regulates something called neuroglobulin, which is a protein in astrocyte cells, which astrocytes are types of cells in our brain. And it actually looking at this one, paper is actually quite technical, but I quite enjoy it. And it's looking how it responds to glucose deprivation when sugar levels are low. So it's quite technical, but it just looks at that beautiful physiology, the natural testosterone, how it works in our brain. Is so important, yet it's been forgotten, and then women have just been sort of pushed in thinking testosterone is only about libido. But when you look how it works physiologically in the brain, it's really, really important. And then quickly before I finish, this is actually a few papers here talking about myocardial infarction and heart attacks. And we know there are some studies showing that women who have low testosterone levels are more likely to have a heart attack, more likely to have a myocardial infarction, more likely to have heart disease. Obviously, that's not saying that giving testosterone will reduce the risk of heart attack, but it's pretty likely because it reduces inflammation in the blood vessels. We know in men it reduces heart attacks. We know in men it reduces type 2 diabetes, and we know it probably reduces Alzheimer's as well. It's not going to be much different in women, it's just the studies haven't been done. But these papers showing that people who have low testosterone levels, women who have low testosterone levels, are more likely to have a heart attack is actually, another soft sign that actually giving testosterone might reduce the risk of a heart attack. And there was some studies a while ago looking at testosterone, synthetic testosterone, showing a risk of heart attack. But actually the natural testosterone doesn't, and this study shows. There has been some studies that showing that women who take testosterone have a lower incidence of breast cancer as well. We need to do more work on that as well. But we've got some studies show that women who have aromatase inhibitors who've had breast cancer, adding in testosterone can reduce their risk of a recurrence or metastatic disease as well. So there's lots that needs to be done. Why? We should be doing so much more research about testosterone. The levels of testosterone can really vary with women, but it's always a guide. So if you have low or normal testosterone levels with symptoms of testosterone deficiency, then ask for a trial of testosterone, or go and see a clinic such as ours and talk to someone about the options. If you're on testosterone and your level's slightly high but you have no side effects, then just have your level repeated. Don't just stop your testosterone unless there's a medical reason to stop it. Because a lot of women tell me they feel better, they have a level that's slightly raised and they're told to stop it straight away. Natural testosterone is actually not dangerous, and when we give it as a medication, it only lasts usually for that day in the body anyway. So a lot of information that I've not really talked about before. I'm going to be doing a lot more over the next few months, really talking about the science and the biology of hormones, because that's what really interests me, and that's something that I feel is really important to share with you. So hopefully you've enjoyed that. If you have, let me know in the chat below, and if you haven't, let me know as well, and I can change in future weeks. So have a great rest of your evening or day, depending on where you are in the world, and have a great week. Thank you.